Hey guys, it's Marshall and Mike from PhysioU, and today for the Mentoring Minute we're going to stick with the knee, and this time we're talking about patellofemoral pain syndrome, a very common condition we see in the clinic. When we talk about patellofemoral pain syndrome, a really good way to assess for it is either doing a step down or a squat. So today we'll have Dr. Wong go ahead and do a squat. I'll do two legs, it's a little easier to change it first. Do a two-legged squat. Now if they don't have any pain or you don't see any dysfunction, we can always progress it to a single limb. But here, if you see his knee kind of diving in, so femoral adduction into rotation, if that's painful, we want to change that. So what I'm going to have to do is, when you squat down this time, kind of push your leg out into my hands. Don't let it dive in. I'll kind of guide you and see if that changes his pain. Right? We're looking to see if we can control the femur, because that changes knee pain. Right? There's another camp that says, well, how about we can control the patella? Maybe it's a patella tracking problem. So adding either a lateral or medial glide, and have them squat again, does that change their pain? If it does, there's good articles that talk about taping the patella to allow them to exercise and get stronger to build up their muscles, not necessarily just taping alone. Now if we go back to the femur control, where let's say he got better with the squat, kind of giving him feedback to push out, right? Well, we want to look at glute strength, right? There's a lot of articles that talk about what are the best ways to predict femoral internal rotation, and really glute max endurance over a table was shown to be the best predictor, as we see here. When it comes down to strengthening, there's articles that talk about, are we going to work on strength or are we going to work on control? If we're working on strength, research shows the best exercise for the highest EMG for glute med and glute max is a single limb squat. As we know, patients with patellofemoral pain, it's really hard for them to do a single limb squat. It's painful. They don't have the best control, so sometimes we have to start at a lower level. And that's where our clams with the band, sideline hip abduction, single limb bridges, are great ways to start, and then progressing to the double limb and single limb squat. Now if we move to the control part, there's articles that talk about using visual feedback. So with a mirror here, Mike's going to work on a single limb squat. Let's just do mini squats. Okay? And they had patients only perform 2 weeks of verbal cues. Right? And the cues were push your knee out, don't let your knee dive in, and they had a lot of them do these running on a treadmill and just looking at a mirror and then watching videotape of himself. And over the 2 weeks, they slowly decreased how much cueing, so that way the patients could internally try to correct it. And what they found was, after the 2 weeks, improved pain with running, as well as really good carryover to a single limb squat and a step down task. So the idea is, do we want to work on strengthening? If they don't have enough strength, yes, we have to work on strengthening. But if they have it, maybe we just need to work on the control aspect of it. All right, hope you guys enjoyed the Mentoring Minute. And again, change that squat. Is it more femur control versus patellar? And then is it more strength versus control, knowing that we know how to treat for both? Take care, guys.